A very warm welcome to all of you, Dr. Pramod, Dr. Richapuria sir, Dr. SMS sir, and it is a great pleasure to have you on board today, all of y'all, to for another exciting session of No Thrombosis workshop series in acute ischemic stroke. It gives me immense pleasure to welcome our course director for today's session, who is Dr. Richapuria sir. Sir is the Director of Neurology at Sahyadri Hospital, Pune. Sir has been part of the first Neuro ICU and Neurointensive Care of Pune. He has been a pioneer in thrombolysis treatment for stroke and has the credit of delivering more than 300 public lectures and workshops in stroke. Sir has also been the member of the Indian Stroke Association, organizing president of Strokeathon, has been the founder of the Pune Stroke Group and ex-president of Society of Neurosciences Pune and Maharashtra Academy. He's been principal investigator for multiple multinational stroke trials and has been awarded as the health icon by the Times of India Group. We welcome you, sir, today. Thank you for being on board.
Thank you. Thank you so much. Thank you for the kind words.
Moving ahead, I would like to introduce a moderator for today's session, who is Dr. Meenakshi Sundaram. Sir is working as a senior consultant neurologist at Apollo Hospital, Madurai. He has over 20 years experience in neurology and has presented papers in various prestigious national and international forums. Sir has received the Best Research Paper Award at the 10th Annual Conference held at Lucknow. He has also been a part of multiple international trials, such as the refractory partial epilepsy stroke, acute stroke interventional trial, and PE trial. He's also been the editor of the South Asian edition of the book's Practical Neurology and has contributed to many books on neurology. We welcome you, sir, today.
Thank you for the opportunity, madam. Thank you.
I would now like to introduce our first speaker for today's session, who is Dr. Pramod Thonde. Sir is working as a consultant neurologist and is the director of Donde Hospital, Nanded. He has the credit of multiple publications in national and international journals. He has the credit of multiple poster presentations in national and international conferences, and has presented in the Tournament of Minds at WCN Kyoto in 2016. He has also been co-author in national publications and has contributed to the chapter COVID-19 and mucormycosis, stroke and CVT-ST. We welcome you, sir, today.
Thank you. Thank you, Dr. Namra.
Our second speaker is Dr. Saksham Jain. Sir is working as consultant neurologist at Park Hospital, Patiala. So without further ado, I would like to now request Dr. Richapuria sir to continue the session.
Yeah, thank you very much, Dr. Namra. I hope you're not fasting anymore.
No, I'm not. I've broken my fast.
You've broken. No, so you're in good.
Yes.
You're in good mental state to keep a check on us. Anyway, so this no thrombosis meetings. I think now this is the second year, and I think we've had 18 meetings or so. And I must say that it has been a great success. And we have seen some absolutely fantastic cases which have been presented by many people across India. And I'm sure I've learned a lot from those cases. And I'm sure everyone who has participated has also learned a lot. And the speakers also have learned a lot. And it is my great pleasure to welcome Dr. SMS. Who is a very, very dear and close friend of mine. And you will see his brilliance as we go along. And he'll always come out with something new and something fascinating for all of us. So the SMS is from Madurai, and he's from Apollo Hospital, and he's an ex-Nemansian like me. And we share a very, very close and happy rapport with each other. So SMS, would you like to say something and then start the proceedings with Dr. Donde.
Thank you, sir. So just recollecting Raymond Adams, neurology is learned stroke by stroke. So we're waiting to learn from stroke cases from you and from the speakers, sir. Thank you very much, sir. Thank you for the opportunity once again, sir.
And I must say, I must also, add to Pramod Dhonde's introduction. And, he's a very exciting neurologist. And he always comes up with something very amazing. And, something that we have not done, he will tell you. So there is a lot to learn from him. And we admire him a lot in our Maharashtra group. And it will be a real pleasure to listen to Pramod. Pramod, I think, could you start your case? And Namrat, could he share the screen and start off?
Should I share my screen?
Absolutely. Will you please start sharing the screen, Dr. Pramod, sir?
My my slides are visible. My slides are visible.
Yes, sir. Your slides are visible.
At the outset, I thank Ichapuria sir for those kind words, and team Emcure for giving me the opportunity to talk on this very interesting lecture series. Actually, I have been one of the part of this series. Initially, I have presented one case of central retinal artery occlusion, which has been successfully thrombolized with tenecteplase, and the patient recovered very well. This was long back, almost I think 1 or 2.
No, little loudly, Pramod. We can't hear you.
I have presented in this lecture series. I have presented one of the talk almost 1 year ago, where I have presented one case of central retinal artery occlusion.
Could you go closer to the mic?
One. Am I audible? Hello.
Yeah, little better it is now.
Yeah. Am I audible now?
Yeah, better. Yes.
First thing, I just thank you, sir, first for giving me those kind words, and this team Emcure, and where this wonderful series is going on, this stroke cases. And I have been the part of this stroke series initially, where I presented one case of central retinal artery occlusion, and which has been thrombolized with tenecteplase, and which has been successfully thrombolized within 2 hours. It was the case, and it was long back, almost 1 year ago. So this is one of the things which is I'm going to present. Age is just a number in stroke. So there are 2 wonderful cases which have recently thrombolized within last 1 or 2 months, and these are 2 cases I'm just going to go. So this is the case 1. She is a 15-year-old girl. While preparing for 10th standard examination, presented with right hemiparesis with mild dysarthria since 1 hour. Initially, we thought that she might be some functional element was there, but power was definitely grade 3, grade 4. There was mild dysarthria, so it was definitely some stroke is going on. So there was no history features suggestive of RHD or any other cardiac disease, rash, joint pains, or vasculitis. On examination, power was grade 3 by 4 in right upper and lower limb with dysarthria with preserved comprehension. Vitals were stable, cardiac examination and ECG was normal, and NICS was around 10 in that patient. So to avoid the stroke mimics, we have planned MRI in this patient, particularly MRI brain screening with angio. In our setup, means it's not in our setup, we take almost 10 to 15 minutes to get MRI done, and traveling distance we can say 10 to 15 minutes. So within half an hour we could get this patient's MRI done. And this was her MRI, and it was showing on the diffusion there was acute infarct in the left gangliocapsular region. The M2 segment was a little bit narrowed and looks thrombosed as compared to the M1. And as we see that there is nothing on the flare, so there was clear-cut flare diffusion mismatch. So we have decision to go for thrombolysis in this patient. And there were some patchy areas in the distal areas of patchy infarcts in the distal areas of this M2. And so patient was thrombolized with tenecteplase with dose of 0.3 milligram per kg at 2 hours after counseling. And next day, patient's NIHSS improved to 4. On discharge, on day 4, she was completely independent. Power is almost grade 4 plus in lower limb, grade 5 in lower limb, and grade 4 plus in upper limb. Later on, her workup was done with echo and carotids were normal. Her other thrombophilia profile and all these things are awaited. So this was the first case which I have thrombolized of 15 years. So day 2 CT brain, it was a day 2 CT brain, which was showing this acute infarct, which hasn't been progressed as shown in the previous MRI. This is another case. He is a 100 years old male and presented with left hemiparesis within 1 hour. And he was sent by one of our close physician, and it was that he was very much, his family was closely related to that physician's family. So they had taken instant decision to go for thrombolysis. Initially, there was in this patient, there was no previous history of hypertension, and there was previous history of hypertension and mild COPD was present. Patient was functionally independent prior to stroke because he was moving, he was doing all his activities, he was going to farms and everything. So we have thought that his physiological age might be around 70, 75, though he is 100 years old. His vitals were stable, power was grade 1 but 2 in left upper and lower limb with NIHS of around 12. So this was the CT scan on the first prior to thrombolysis. There was previous gold ischemic changes were there, but then nothing on the right side. So it was decided to go for thrombolysis. As patient was fully independent prior to stroke, decision of thrombolysis was taken with tenecteplase within 1.5 hours. Next day, patient had improvement in the left lower limb to grade 3/4 on follow-up independent over 1 month for daily activities. After 1 month, he is completely independent. There was some deficit in the left upper limb, but still he could walk to bathroom and do his own activity with the help of family members. On workup, patient had significant right ICA thrombosis in this patient particularly. This was the second day CT scan, which was showing this right gangliocapsular infarct. So in these two patients, these are the extremes of patients. What do guidelines say about this? This is the one is 15 years, another is a 100-year-old. So these are very interesting phenomena which we have seen recently. So these are the particular guidelines, what they say that American Heart Association guidelines 2019 and US FDA guidelines instead of 2015. Indications: diagnosis of ischemic stroke with disabling neurological deficit regardless of severity. Symptom onset within 4.5 hours. Wake up stroke with diffusion weighted flare mismatch on MRI. And age more than 18 years. While in US FDA admits to say that it is more than 75 with risk factor less than 75 with risk factors for intracranial hemorrhage. So contraindications, as all of you know that these are the contraindications. Now these are the things where the standard what workup should be done each and every patient of stroke. This is the workup which has been told class 1, class 2A, class what is class 1 guidelines, what is class 2A guidelines, class 2B guidelines, where we should stop in each patient of stroke. These are the first in ischemic stroke is there CT MRI, obviously it is class 1. ECG and basic laboratory test class 1. Then if it is ischemic stroke is there, echocardiography to evaluate cardiac source of embolism class 2A. For if it is anterior circulation infarct, if it is there non-invasive cardiac cervical carotid imaging CTA or MRA, that is ultrasound, or ultrasound, that is class 1 indication. And these are the various indications which are the rest of the indications are class 2A indications. So whenever there is cause is identified, if cause is identified, manage accordingly, thrombolize and all these things are. If the cause is not identified, then what should be the rest of the investigation? Long-term cardiac rhythm monitoring class 2A, test for genetic stroke symptoms class 2A, test for infectious vasculitis class 2A, and TEE cardiac CT or cardiac MRI class 2B, and evaluate for other rare causes of stroke. So this is the basic workup which has been told in the guidelines. And what are the basic laboratory tests which are mandatory? It is said that CBC, troponin, prothrombin time, partial thromboplastin time, glucose, hemoglobin, HbA1c, creatinine, and fasting or non-fasting lipid profile. So this is the basic workup in every patient of stroke should be done according to the guidelines. So now the data for what I'm going to talk about the pediatric stroke part. What does this data about say that this is one of the article from thrombolysis for ischemic stroke in children, data from nationwide inpatient sample. This was from 2007, and these patients were included from 1 to 17 years in this nationwide. And the most of the patients were around 9 to 11 years in these patients were there. That it is around 2,904 children were admitted with ischemic stroke, of which 46 children received thrombolytic therapy. Children who received thrombolysis were on the average elder, that is 11 versus 9 years, more likely to be male with significantly higher hospital costs. And these children were also likely to be discharged with higher rates of death and dependency, although differences in clinical severity between two age groups was not known. So thrombolysis, though not indicated for patients less than 18 years of age, is currently being administered to children with unclear benefit. Larger studies are needed to evaluate the efficacy and safety for treatment for children. So it was an old article, but just giving you the idea of what thrombolysis has been showing results in the ischemic stroke in children. So this is regarding pediatric stroke. So this is basic guidelines from continuum what the pediatric stroke should be managed. This is a clinical presentation, whatever has been shown. High level of clinical suspicion of stroke should be there. Then preferably MRI to be done, radiological assessment after that. If it assesses eligibility for intravenous and need for interventions and need for transfer, intervention decisions depending on the patient's condition, it has to be thrombolized, or you can do the interventions in those patients and accordingly managed. So this is just the basic guidelines which has been shown in the what should be done in the pediatric stroke. So these are the various risk factors for pediatric strokes: genetic predisposition, that is structural, like congenital heart disease, genetic arteropathies, collagen defects; then genetic predisposition, hematological disorders like hereditary thrombophilia, sickle cell disease; and acquired exposures like infection, trauma, radiation, and drugs. So these are the various etiologies for pediatric strokes. Then this is very important thing in secondary prevention of stroke. What should be done in children with ischemic stroke who do not have sickle cell disease or cardioembolic stroke? Pediatric stroke guidelines from AHA or Royal College of Pediatrician and Child Health and AHA recommend secondary stroke prevention with aspirin, 1 mg per kg dose to 5 mg per kg dose orally once daily if there are no contraindications. Anticoagulation is typically recommended in children with presumed cardioembolic stroke and significant thrombophilic states such as antiphospholipid syndrome. Although anticoagulation is often used in cervical artery dissection, recent AHA and ASA guidelines note that use of anticoagulation as opposed to antiplatelets is controversial. And what is the duration? Optimal duration of aspirin use following childhood stroke is not known, but the guidelines recommend a minimum of 2 years, and it is sometimes used indefinitely. So these are the various things about secondary stroke prevention in pediatric strokes. Now, what is the elderly thing? What is the what we have done in 100 years? What is it safe to do thrombolysis in those patients? So safety of thrombolysis in patients over the age of 80. This is the 2012 neurologist article where the safety of IVT in patients with acute ischemic stroke over 80 years has been trial had been done. The results were that 112 patients over age 80 presented within 3 hours of ischemic stroke onset, and 31 received IVT. There were 15 deaths in this trial in multivariable models adjusted for age, sex, and race, ethnicity, and NHS. Treatment with IVT compared to no treatment was not associated with in hospital death. So conclusion was that in treating ischemic stroke patients over 80 with IVT was not associated with an increase in mortality in an urban tertiary care center. This was the conclusion from 2012. In order to show a more robust clinical benefit in those over age 80, registries and clinical trials will need to consider pre-morbid function status, stroke severity, and meaningful clinical outcomes. These are the 3 things which are very necessary to select patients very wisely for stroke thrombolysis. So questions again, what's the deal with the age? Functional status is more important. Time duration of antiplatelets for pediatrics, I would like to learn from the all of my teachers where what has been told that it is 2 years, whether it is necessary to 2 years or what should be the timeline for pediatric strokes. Then whether RTPA versus tenecteplase at the extremes of ages, what's better? Whether there is any data where it is showing in my 2 patients, the tenecteplase have worked very well. This was the thing which has been, I had taken from Louis Kaplan's book of stroke. Josh Thibault said it well. He is one of the colleague for Dr. Louis Kaplan. He said that we then need to decide which approach in our large therapeutic armamentarium will be most appropriate in a particular patient with a particular stage of disease and particular coexisting conditions and at a particular age. Even when randomized controlled trials have been performed, which is true for only a small number of clinical problems, they will often not answer this question specifically for the patient sitting in front of us in the office or lying in the hospital bed. So you have to take a wise decision. According to the guidelines will help you, but you have to take the decision in that particular patient which to thrombolize and not to thrombolize. Then this is one of the wonderful article which I was just reading, Evidence and Effective Clinical Neurologist by Louis Kaplan. This was a 2009 Boston Merit Lecture. It is said that, I will just briefly tell that it was sentences. Choice of therapy considers the benefits and risks of each potential treatment for that complex individual. It is necessary to have substantial knowledge about the patient and his or her social milieu and psychological makeup. This approach can be considered as personalized medicine because it emphasizes the medical and personal pitfalls of each individual. This system was taught by Dr. H. Austin Bennett and as said by Dr. Louis Kaplan. Then what is this? Recently, there has been a major thrust to demand that all treatments become evidence-based. The highest level of evidence is derived from the RCTs that consider treatments rendered to large groups of patients with general diagnosis. This approach is best suited to choosing treatment for the large bulk of patients with a general condition and can be characterized as group medicine. So there are two things: personalized medicine and group medicine. Whenever there is a large bulk of patients, like suppose upon 18 to 80 years, then you can think of this group medicine. But these extremes of ages, then you have to think of personalized medicine in those patients selecting for thrombolysis. So now there is one example I'm just telling you, I want to share with the crowd, because there was recently, almost I think 6 months ago, there was one patient of only 2 years baby. We have been percolated this knowledge of thrombolysis in society in our area very hugely. There was the one patient, which that patient was 2 years only. He was having right hemiparesis. It was just a transient cerebral arteropathy in that patient, but he came for thrombolysis in that, even that for 2 years also. That was the thing we have done here. So that was the trust model we have developed here in Nanded, and in nearby area, that patients were thrombolized extensively. Even physicians are doing it at their own centers now. At the beginning, only in our area, why these patients are get ready easily, because at the beginning only treatment is discussed, charges later paid for our admission as well as TNK or RTPM. When the patient comes to our center, we go to get CT or MRI done. After that, we discuss the treatment part, and after that, charges, all these things we just tell them. But never we have been deceived by the patients or their relatives that patient charges were not paid. So charges were taken later, because in our area there are all, though nobody carries this insurance, nobody carries this cash of 50,000 or 40,000. So that was the thing we do in most of the patients. Almost every staff is aware of it, including ward boys. First question on arrival, when patient was last time okay. This was the question which has been taught to everyone in our hospital. And main crux is our good rehabilitation. We have a good rehabilitation care. We have Shivansh Neuro Rehabilitation Center, where after the discharge we could do this, we gave this service. So that this trust model has developed into a very huge area now. I think what these connected place people were telling me that we are doing in last 10 years, we have done, I think, 200 patients of thrombolysis in our hospital only. So this percolation of knowledge has been given to most of the physicians in our area. So these thrombolysis are happening because the trust model has gone in exuberantly in our area. So this was the one dialogue which has been given by in the Louis Kaplan's books. Some men see things as they are and say, why? I dream things that never were and say, why not? So seen by George Bernard Shaw. And with this, I end my talk. And I again thank Team Emcure and Ichapuria sir and SMS sir for giving me the opportunity to talk on this, one of the extremes of age of thrombolysis. Thank you once again.
Yes, Dr. SMS.
Sir, completely floored by the fantastic presentations. True, whatever you said, sir, really. Thank you very much, Dr. Pramod. Fantastic, really.
Thank you, sir.
Two extreme ages. And I know next time you're going to come up with another presentation, 1 year old and 100 years old. That will be the icing on the cap, really, from list. Now, only a few interesting things, only about pediatric stroke. We also do not know how long to give, antithrombotic therapy for them. I leave it to the judgment of the family rather than us. That's what I've been doing so far. We really not know. When the etiology is clear, at least we have guidelines. Etiology is not clear, we have no guidelines. Regarding the thrombolytic therapy in pediatric strokes, one of the difficulties is that, see, why they could not take it forward so easily is because the fibrinolytic system is not mature in young people, in those young people. So because of this system, for example, the level of plasminogen activator inhibitor is very high. And you may require a higher than usual dosage to give the same result in terms of milligram per kg body weight. The dosage requirement may be more because of the immaturity of the fibrinolytic system. Fortunately, there is no leukoariosis in them, and therefore the chance of bleeding is less. The exact dosage, I believe, is not known in pediatrics. That's one of the difficulties. I think there was some NIMS data on, thrombolysis in pediatric stroke data. I think the study was dropped because they couldn't, and the exact reason why it was dropped, I do not have that. I think it was 13 years. That was the lowest I have gone to. I have not got any experience less than that. I'll take experience from sir. Sir, what have you done, sir? What is your comments to us, sir?
Yeah. Pramod, why did you give 0.3 mg per kg?
I thought that this was M2 was occluded now, so it was embolic stroke. So I thought that it is little bit more would be better rather than lesser would be. It is 0.25.
I think you should stick to, general guideline is 0.25.
Yes, sir. Yes.
So let's stick to that because, we don't have data for 0.3 mg per kg. And what do you think was the mechanism of stroke in this child?
Actually, it was looking like an embolic stroke. ESS must be there because there was nothing on this card. Echo and everything was okay, but I don't know the source of embolism where it came from.
Why do you say it was embolic?
Because M2 was involved, no, sir. It was not.
Yeah, but the infarct was a like a lacune, no?
It was left. I think it was left gangliocapsular.
Yeah, but it was small. It was like a giant lacune, not a small lacune.
Actually, for
So it was like a penetrating artery
thrombosis
involvement. That is what I thought, rather than M2, because there was no cortical involvement. M2 should produce a cortical infarct.
Yeah.
On the superolateral surface. This was in the basal ganglia.
Yeah, basal ganglia, but
more likely that
peripherally also, sir.
Huh?
There were some patchy areas of involvement of peripheral.
Can you show that picture again, if possible?
He showed
Yes,
those two
SMS?
dots there, sir. Beyond the gangliocapsular region, he showed two other dots, sir. I think that's what
let's
made us
just see
think
that.
sir.
Let's just see that again.
That is what exactly correct.
Yeah, okay.
Two dots there.
Yeah, these two dots. But the main infarct was where?
Basal ganglionic, sir.
Yeah.
Actually, sir, in this lacune, if we take the hypothesis of lacunar stroke,
no, I wouldn't say it is a lacune. It's a little more than that. This is the ADC. Yeah. It's in the same vascular territory. So, if we say embolic, then it should be embolic means from where? Cardioembolic or artery?
Artery to artery, carotids and echo were normal, so I don't know source of embolic source.
So, I think more likely that it is some type of vasculopathy or vasculitis or something like that involving small vessel and maybe one or two peripheral branches. That is what I think. And how much was the NIHSS you said?
Around 10 to 12 was there, sir.
10 to 12. No, you've done a great job. There's no doubt. I mean, these are just some points which I thought. And I think as of now, we should restrict ourselves to 0.25. There was a lot of discussion whether it is 0.2 or 0.25. Now, more or less, we've come to the conclusion that 0.25 would be the best possible dose. More than that, the risk of bleeding increases. So I think let's stick to that for the time being, at least till we have more data. What do you say, SMS?
Yes, sir. The dose escalation study 0.1, 0.2, 0.3, 0.4. 0.4 clearly showed hemorrhage, 0.3 tending towards hemorrhage, and that's how 0.2 was taken up till the ACT data came when we switched over to 0.25. And was the CT angioedema, was it because in children we'll be thinking of dissection as an important cause? Was there a CT angioedema to look for dissection?
Because carotid Doppler was only done, and it was not showing any vertebral artery involvement as such, the carotid Doppler.
No dissection in the Doppler specifically. I think it's still, I think, can go ahead and look at for this, because that's an easily treatment. At least be able to give the prognosis to the family. When we are having a dissection, the child has improved. The long-term prognosis is going to be good. Otherwise, we'll have always the lingering thoughts. The parents will keep asking us whether it will recur, sir, recur, sir. All the other etiologies are going to have some recurrence. Any of the genetic causes you will think of, or an arteriopathy, or any of those things. That's the reason why I was specific about dissection.
Any other tests you did?
Prognosis.
Homocysteine? Was she vegetarian?
Homocysteine was normal, sir. She was not vegetarian. She has means non-vegetarian.
B12 level?
B12 level was normal. The homocysteine and B12 level were normal.
Yeah. So sickle cell also was negative, no?
Yeah,
Sickle cell, thalassemia, alpha thalassemia. We'll have to look for all these rare causes. 2D echo, T, PFO.
PFO, how much we should be stretched for in these patients? So P.
In pediatric stroke, it's not so much atherosclerosis, no. So we'll have to look for something else.
Right.
So definitely a good 2D echo, and preferably a T, and to look for PFO, or to look for some other, ASD or something, some congenital heart disease, rheumatic heart disease, mitral valve involvement. We would definitely push it hard, for etiology wise, because then, the prognosis changes, the drug therapy changes. Suppose we find a PFO, then, and if it's big and if a stroke has occurred, we may think of closing that PFO or something like that, So we will have to push very hard for the etiology. Many times you cannot find the etiology, even after, it's cryptogenic stroke, and you can't find what you want, I mean, as far as etiology is concerned. But certainly I would, go all out for diagnosis, AF, look at aorta if there's anything. It's not atherosclerosis, no? So in a 15-year-old girl, some vasculitis, ANA blot, ANA.
We have sent now. ANA blot we have sent. The report will come, sir.
Say that again.
ANA blot we have sent actually. That report will come.
Okay, that report will come. Yeah. So the point is that we should push hard for the etiology, because the long-term treatment will change depending on the etiology, and it's not an atherothrombotic stroke. So we don't know, and it's good that you've see, there is no guideline, but that doesn't mean you can't use the drug. See, people say that no, it's not in the guideline. But the study is not done, so how can it come in the guideline? So, you have to have a large number of patients to mount a RCT at multiple centers to get the guideline. Abhi, now, if the patients are so few and so far between, how can you get the guideline? So there will be no guideline. So as you said, it will have to be a personalized medicine. It will have to be what you think is best at that time. And, there's no time to think. Now, as you said, first we thought it was functional. It could be, it could be migraine. It could be a stroke mimic. But obviously it was not. But even if it is a stroke mimic, it's okay if you thrombolize. Where's the problem? You have to save the person's life, and you have to save the person's limb. So, all these things, it's not in the guideline, therefore I will not give. Aisa to nahi hai. It's not like that. It's not like that. So, because the study is not done, it cannot be in the guideline. So, use your judgment, use your thing, which you have done most elegantly. And, you've saved the child from hemiparesis, which is a fantastic thing that you have done. So,
what is your,
some purists will say that it's not in the guideline. That doesn't mean you can't treat. See, off-label does not mean that you are doing unethical things.
Yes.
It's off label. It's not written in the product insert. It's off label. Off label does not mean that you cannot treat. Yes, you take a proper detailed consent. You tell the family, Kare Baba, this study is not done, but still we have to treat the patient at hand. And the small risk is there, as SMS said, risk of hemorrhage in a child or even with a stroke mimic is very minimal. So definitely we should treat. I mean, I see no reason why you should not treat such a patient. And of course, etiology, then, see, time is of the essence. You can't find etiology in 1 hour, surely. That will take another 2, 3, 4 days to find. So that doesn't mean you should not treat. I mean, this is my view. What do you think, SMS?
Yes, sir. Sir, CT angio, again, I would recommend Dr.
Yes,
Pramod
yes.
for one more reason. One
So
is
I
that
think you should not leave any stone unturned, Pramod, and go all out and try and find the etiology by whatever method. You may not find. It's okay. There are so many 50%, 40% are cryptogenic stroke you can't find, but you must make the effort. And I think so. Congratulations to you. Now, regarding the second case.
sir, there's one more thing, sir.
Yeah, SMS, yeah.
Could this have been the first episode of Moya Moya?
It could be. See, that's why this vasculitic thing. So only thing is that M2 it was, no? Moya Moya is more distal ICA.
So ICA were okay, no?
Yeah, so distal ICA, should get involved with Moya Moya. But we'll have to follow up, we don't know. But here, M2 was not perfusing so well. So perhaps it's a little distal for Moya Moya. Moya Moya should be a little more proximal. But sickle cell you said you saw, no, Pramod?
Yeah, sickling was negative.
Yeah, sickle, yes.
Sickle cell you saw, yeah. So
some rare genetic disease like adenosine deficiency.
Yeah. There are genetic. Yeah. So, for these rare things, you can do a genetic workup also, Pramod.
Yes, sir.
I mean, if you really want to spread the net, and really you want to, then there could be some gene. We don't know.
Actually, what we do initial days, we do just all these basic workups, whatever in the most possible way. Actually, majority of the times we do get answers over the bit of time. Something happens to the patient, then the answers come. So accordingly, we try to justify the investigation. So initially, to do the genetic workup and all these things, it's very.
I think genetic would come last. First, you look at other things. It's expensive also, and we don't know. But there could be something. I mean, see, we don't know. That doesn't mean it's not there. It's obviously there. So we should look at that. Regarding the second case, SMS?
Yes, sir. Same thing, sir. Age is not no bar. All those data are only for the sake of trial data. And in fact, you have first shown us, I think you did one in 100, correct, sir? Long back, you showed. And Balmurugan has done 100.
Yeah. See, Pramod, you showed all that, those are all little old. More than 80 and more than 77. That's all given up. So age is no bar. At least the patient should be mobile and he should not have dementia. So, one of the things is, MRS pre-treatment should be more than 3. Sorry, less than 3. If it's a bedridden patient at 100, then there is no point in doing.
Yes,
okay. Or if he has got some severe arthritis and he's not able to walk, or he's got dementia, they come, fellow who's got dementia. Recently, we had a case, very elderly, 90 plus. He was dementia and he was bedridden and now he had a stroke. So this type of case you won't do. But your patient was mobile. He was going in the farm. He was a tough chap. He was working in the farm. That's something great. And it's not that he has to work, but the family also suffers with an old person having a disability. So it is not only for the patient. Of course, it is for the patient, but it's not only for the patient, because then, you have a dependent elder in the house and the whole family gets disrupted. So don't worry about age. I think that is given up long ago. And don't worry about timing. You can get, there was a recent, when that ECAS 3 trial came, they said no, above the age of 80, it's up to 4.5 hours not allowed, only up to 3 hours. All that is given up. So you can thrombolize till any age. Age is no bar. There's no upper limit. And the 90 plus people, they don't do so well, but 80s, so definitely you should give. There are so many people, many of our teachers are 90. So you think we should not give them? I mean, of course we should give them. So many of our mentors are 80 and 85 and 90. So, and they are very good. They are in good health. They are walking. They are contributing to society. So, definitely no contraindication. And you use the same dose?
Yes, sir. In this patient, 0.25 milligram. 0.25 milligram per kg.
Yeah. And another thing, I think I must congratulate you because, you've developed that stroke ethos in your area. It's not easy. All the ward boys know about it. All the ambulance drivers know about it. All the emergency room staff know about it. And as you said, the first thing they ask is, when was the last time normal? So that ethos, and that stroke team to develop, you'll be surprised how very few stroke teams there are in our country. Everyone's just working at an individual level, and it's not effective. And, unless you have that stroke team and that stroke, this thing, you cannot hit centuries. You cannot hit centuries. You will do 10, 15, 20. But, if you want to hit centuries and be a Jaiswal, you will have to develop a stroke team, and it will give you tremendous pleasure. I'm telling you, it gives you so much pleasure. It gives you so much satisfaction. And you can't work 24/7, 365. Come on, you can't. And you should not. You should not. So, you have to delegate. You have to, and which you have done very brilliantly, I must say. And also, I need to tell the audience that Pramod, he's not stopped at acute thrombolysis. He's developed a very good rehab center. So, many of our patients, they go to all quacks all over Maharashtra. I don't know what it is in Tamil Nadu, but in Maharashtra, they go to all these stupid quacks who give all sorts of vitamins and charge patients and, do all sorts of crazy things. So, we as neurologists have to develop this rehabilitation facility, which Pramod has done, I think, very successfully. And Pramod, can you tell us in about 2 minutes what is this rehab facility?
Actually, sir, we have developed one rehab center where there is one floor area is for only patients workout. It's like a gym for the patients. Every instrument is there, like virtual reality, functional electrical stimulation, treadmill is there, overhead harness is there, functional trainer is there, everything is there. And there is one area where we have rooms and rooms and flats are there, where patient and relatives can stay for months together. And 2 sessions are there each day, has been done for at least 1 hour, 1 to 2 hours. Every day they are doing sessions. And the results are amazing, sir. We have done one poster presentation, one of the neuro rehab CME. Within 6 months, the results are at any age, you can say any age, whatever type of stroke, it is definitely patient becomes independent. I guarantee that. Second thing, if it is more than 6 months, it will take more time. But within 3 months or 6 months, definitely patient will walk out. And our target is that whenever we tell the patients who get in the center that you have to become independent for at least for bathroom, then your work is done, your family's work is done. So that is our targeting area. So when the patient walks to the bathroom, we just discharge them and let the remaining things get it done at home.
SMS?
Fantastic, sir, really. Wonderful service, Dr. Pramod. Fantastic.
I will tell you, this is more satisfying than your clinical work. When the patient comes you and thank you, that is today only one lady was there for almost 3 months. She was staying here and she came walking today. She was having COPD, multiple RT on RT feed for at least 1 month. But she's going independently for bathroom within 3 months. I'm telling you. So that is really wonderful to see and to talk to them and every day. That is very very nice thing to do. And I think everyone who is related to neurofield should have some rehab setups, and they should give inpatient IPD facilities for those patients, because it's very difficult to do at home. Because whenever I tell them you have to go to the, if there is gym at your home, will you do the exercise there regularly? If you go to the gym outside, then you will do that, because there is some environment goes on, because there are multiple patients are there in that setup. So they get motivated by
And
this
trained staff also, no? You need, it's not only gym, Pramod. It's not only gym. It's also the trained staff and the commitment, no?
We have almost 5 to 6 staff, and there is one physiotherapy college. Interns come to us, our center, for a training purpose. So these things we do very regularly. So this is very satisfying. Rather than our clinical work is definitely, it is always better, but this thing should be done in every neuro field, I think.
Yeah, wonderful, wonderful. We've had two very wonderful cases, and the message has gone across, I think, to many people, how we should deal with the very young and the very old, and how to develop a stroke unit, how to develop the acute stroke management, and how to develop and why you should develop stroke rehab facilities. So the full gamut of stroke treatment, I think, Pramod is doing. So many congratulations to you, and very good presentation, I must say. Thank you, Pramod. SMS, any last words?
No, sir. We can move to the next case, I think, sir.
Yeah.
Thank you, sir.
SMS, will you take up the next case?
Sir, you take up, sir. We'll
No,
learn
you
from
take
you,
up,
sir.
man. Come on.
It'll take some more time for me to teeth in, sir. Really.
Namara, can
We
you
have the next case, sir.
can you introduce Dr.
Yes,
Jain?
sir. Unfortunately, Dr. Jain won't be able to join us. He's got
Dr.
engaged
who?
with an emergency case. Dr. Saksham Jain.
Okay.
He won't be able to join us because he's got engaged with some emergency case.
Okay, okay.
Yes. So I think we can conclude.
Okay, so we can continue. Acha,
We can
Pramod.
conclude.
So, okay, so good. We have some more time with Pramod. So we can pick his brain a little more. We can pick SMS's brain also. SMS, what have you done in your center for this stroke
Rehabilitation, sir.
unit and stroke pathway?
Sir, we established our stroke unit in 2003, sir.
Yeah.
In our hospital, we had a place where actually attenders were placing their clothes for drying. We chose that place and built a stroke unit. Fortunately, it built on. We started with 7 patients. Now we have 11 patients in the stroke unit, sir. It is always running full. We are very happy about it. And so much popularity has been gained for stroke unit that many times patients who are sick, who don't have stroke, but they have some other type of things like, they have a head injury and they have a tracheostomy, they depend on us for making life better for them. So we had a dedicated stroke unit from 2003, sir.
What advantage is there of a stroke unit?
So one thing is that the staff there knows. The only thing, even when you look at the guidelines, stroke unit is something where we have the same staff who do the same stuff and who are aware of this. It is just a designated place where facilities are available. It doesn't have to be a ICU kind. It doesn't require any ventilator or anything. All it requires is trained staff. That is more than enough, number one. Because even if the grade 1A recommendation, if you look at that, just by having one stroke unit, a designated place of stroke unit, that itself has got a bigger NNT, that it gives a better response to the patient just by telling this is a stroke unit. That's quite a surprise for us. So we have dedicated stroke unit on that. And we have 2 wonderful colleagues working with us, sir. 2 of my colleagues, Dr. Suresh and Dr. Karthik, they are always with us to give support. And we have a dedicated team. So this is regarding the stroke unit, sir. Regarding the rehabilitation, which he is talking about, we have all heard of the Aravind Eye Care Facility. It's a good organization and one of the nation's top eye hospital. One of the persons who is important in that is my classmate, Dr. Aravind. He also had a passion of establishing a rehabilitation unit, which we started. I don't remember the year, sir, maybe 2007 or 8. I do not know exactly the year when we started. So he had the muzzle to do it actually. So we got people from abroad to come and visit our Madurai. We got people from CMC Vellore, and then with that, about a couple of years we took to establish a wonderful rehabilitation unit called Live Well Institute of Rehabilitation in Puvandi. You can go through the net and you can see that it has been there for more than a decade now, I'm sure. I'm not sure about the exact years, I'm not sure. It has been doing a wonderful, as Dr. Pramod was saying, once you have a proper rehab facility, it's really wonderful. After that, you really take off. Started with around some 15 or 20 patients. Now the capacity is 50 or more. And still it is always full, but that is a need for rehabilitation, not only just stroke, all things. And our Apollo, this was one of our dreams. We have our major unit that is Apollo Madurai. We have another two sister concerns. One, it is a place called Karaikudi, which is around 90 minutes drive from Madurai. That's a Karaikudi Apollo Hospital, where now we have established a rehabilitation center there. So the advantage is that if a patient is on tracheostomy or any of those things, then we cannot send to the other center because any emergency we will not be able to handle from the other center. So patients who do not have tracheostomy, do not have a peg feed, those patients will go to Live Well Institute of Rehabilitation, Puvandi. Those who require some medical care, like a cardioembolic stroke with a sitting cardiac embolus there and patient is unstable, or a patient who had undergone a CABG and then developed a stroke and the EF is only 30%. These people we send only to our Karaikudi unit because medical facility will be quickly available. It is part of our hospital. The two rehab units we established. You can see
Yeah.
in the net, Live Well Institute of Rehabilitation, Puvandi. It's available in the net. You can all see that. Dr. Aravind, my schoolmate, who was instrumental in that.
Yeah, so as stroke neurologists and neurologists, I think we have to develop these rehab centers. It's a very crying need of the country, and there are very, 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 very few really good rehab centers. And talking of the stroke unit, the stroke units have been shown to decrease mortality and morbidity of stroke. And it is more effective than thrombolysis. Thrombolysis, we say, is effective and it decreases morbidity and perhaps mortality. But the stroke unit admission is more effective than thrombolysis and doing all those fancy things. And what do you do in a stroke unit? You control fever, you see for swallowing, you see for prevention of DVT, for lung infection, for early mobilization, starting early aspirin. They sound so simple, but you'll be surprised how many people die of aspiration, how many people die of infection after a stroke. They're kept somewhere and somebody feeds them in the lying position or when he's drowsy. So, doing the swallowing assessment by the GUS score or any other score, simple things, managing fever, because fever, increases brain dysfunction and neuronal death. So, simple things like that, DVT prophylaxis. It's surprising how very few patients of stroke get DVT prophylaxis. And, they die of pulmonary embolism, few of them, but they do. And, so this is what a stroke unit does. Of course, in the stroke unit, we keep patients who have had recent thrombolysis, patients who are, really bad, who have, say, a brainstem stroke or a large MCS stroke who need surgery. So it can be for post-op. And also, after MT, you require. So it is you need not have an ICU, but if you have an ICU, a stroke ICU or a neuro ICU, which doubles up as a stroke unit, it is definitely more effective. And this has been shown in umpteen studies all over the world, that a small designated hub area, maybe 4 or 5 beds, but the same nurses are treating, the same physiotherapist is coming, doing early mobilization, swallowing assessment is done, infection control is done, and this really improves quality of life and gives very good results. So it's even better. We think that stroke is only thrombolysis. No, thrombolysis is one part of stroke care. It's an important part of stroke care, but it's a fashionable and exciting field. So everyone talks of thrombolysis. But the less exciting field is to give good stroke care in a stroke unit and to do rehabilitation long term over months. And these really improve stroke care, which is sorely lacking in our country. Sorely lacking. We've been shouting from the rooftops that stroke care is so poor, so poor. But all of us should make that effort. Even physicians. Why do we say that only neurologists have to do thrombolysis or give stroke care? No, physicians have to do, and we want more physicians to do. They need a little training, okay. They need a few months or few weeks of training to interpret a scan and to learn about thrombolysis. You can't learn it so easily. It's a little complicated, and you have to be a little careful. You can't just do it like that. So a little bit of training in stroke management for physicians, and you'll be surprised how well physicians are doing, many of them, in remote areas. Remote areas, huh? I'm not saying in urban areas. The urban area fellows don't do. The remote areas fellows always are doing much, much better, and I'm really so happy and thankful to them, And then if they have a difficult case, they talk to us. I mean, everyone has difficulty. Everyone needs to talk to each other. You can't be God. You can't know everything. So I think this is the message that, we need to give. And I think Pramod is doing exemplary work in this. Stroke unit is there, rehab is there, thrombolysis is there. So these simple things to do for stroke care, I think, will go a long way in treating our patients better, which on the whole, they are neglected. On the whole, I wouldn't say across the board, but a lot of work needs to be done. And all these quacks, we have to get them out of business. They are seeing 100 patients per day. 100, 200 people are going to these quacks. In Tamil Nadu also, there must be enough SMS, all these quacks treating hundreds of patients. And we are not treating 100 per day. Those rascals are treating 100 per day. So the patients are there. We are not tapping them. We are not going into the community. We are not educating people. The fault is ours. I mean, stroke care is not only sitting in air-conditioned room. It is going out in the field and sweating it out and, giving public lectures and giving demonstrations. And that is what real stroke care is all about. So I'm very happy that we've talked about all these very important aspects of holistic. So I think today's thing has been more holistic than thrombolysis. But of course, thrombolysis, Pramod's cases were excellent. And I think we've had a great session. We are running short. We are coming to the end of the time. So if you have any words to say, Pramod, last few words.
Actually, sir, what we do, even if patient comes after thrombolysis or something like that, we tell each and every patient and their relative, if you come within this hour, it would have been, this treatment is available.
No, we can't hear you. We can't hear you.
When patient, any patient even after window period, patient comes to us, we try to tell the patient and relative that this treatment is available and you should come earlier. So the education has widened up in those cases also. It is not limited to that patient only. So what we do is educate each and every patient of stroke, even if it is lacunar, everything, we just tell them within 4.5 hours, within 4.5 hours, everything, and tell them about this, be fast. So these things we try to do each and every, because these are the patients which are very much educative, because they tried, because they have suffered, no? So they learn very fast, all these things. So this is the way we try to teach them, and that's why the numbers have gone very large now regarding the awareness of stroke thrombolysis.
Yeah, so we want you to hit 1,000 cases now, Pramod. You've hit 200, but now Abhi, you have to go to 1,000. SMS, anything else you want to say?
Just recollecting our beloved teacher, Professor Dr. Tally, sir. He was very passionate about rehabilitation, sir. I've been with him really. very, very passionate about rehabilitation. And then Dr. Shivraman Nair, our senior. Both of them have been very passionate. Dr. Tally said, really, he would inspire us. We would wait for those Monday rounds in the rehab ward. I happened to work with Dr. Tally sir in the rehab unit for 3 months, sir. It's a real eye-opening experience. I think stroke rehabilitation needs to be established all over, sir. Fortunately, in Tamil Nadu, there are many centers which are now coming up for rehabilitation for stroke, especially. And that should be the order of the day, sir. Because we people, we just give them treatment and say, you go home. And the poor wife is looking at us how to feed him, how to really clean him up, how to cut the nails. These are very difficult things, sir, really. In stroke unit, as you said, the simple things. We have made a chart called the patient education chart, which includes how to teach the wife to cut the nails. Even that becomes really surprising to know that how many people really struggle in that. They are afraid of doing it, to giving feeds by nasal tube, nasogastric tube, to teach them to clean up, to tell them about the pressure source. All those things will require a lot of training, sir. And stroke rate is really lovely in that.
Dr. Namra, can you take it ahead now and conclude?
Definitely. So it was a wonderful session. And I came to know like all of us, and particularly on what is the importance of setting up a stroke unit and stroke rehabilitation center, the wonderful work that you are doing, Dr. Pramod, Dr. SMS, Dr. Chaporia, sir. Thank you for providing time for this meeting, and it was a pleasure to have you all today for this session. I would also like to thank Dr. Meenakshi Sundaram sir and our speaker Dr. Pramod Dhode sir for the interesting cases which you presented. And I'm sure the attendees might have enjoyed today's session. So the total number of attendees is 320. Sorry, 320 was 350.
How much?
350.
350 is a good number. At least the message has gone to 350 neurologists, physicians. So I think hopefully, as SMS said, stroke by stroke, meeting by meeting, we want to improve stroke care in the country.
Yes.
So this is by meeting, we are trying to improve stroke care. So we may or may not succeed. I don't know, but let's make an attempt.
Why not? George, as said by George Bernard Shaw. Why not?
Yeah, of course. Why not? Yes, Namra.
Okay.
Can we?
Yes, soon we will be meeting for another interesting case discussion. Till then, thank you so much for this event, and good night.
Thank
Good
you,
night.
sir. Thank you, sir.
Good night. Good night.
Thank you, sir. Thank you, Dr. Pramod, sir. Thank you.
Thank you, sir. Right.